Hello and welcome to our new topic. Today, we'll explore the major drugs used to control dyslipidemia, a critical risk factor for atherosclerosis and cardiovascular disease. We'll discuss their mechanisms, therapeutic effects, and clinical relevance in managing abnormal lipid profiles. So, let's start. By the end of this lecture, you should be able to describe the drug targets in various dyslipidemias, classify them according to mechanism and site of action, explain their pharmacokinetics and therapeutic uses, and understand rational drug combinations to use clinically. The lipids are transported in the blood via the following two parallel running pathways, using different types of lipoproteins, classified by their density and composition, as follows. First is the exogenous or intestinal pathway for dietary lipids, which comprises of 4 steps including 1. Digestion and absorption of dietary lipids, 2. Chylomicron formation in circulation, 3. Tissue delivery of triglycerides, and 4. Liver uptake of chylomicron remnants. Ingested triglycerides are broken down into free fatty acids and monoglycerides in the small intestine through the action of bile salts for emulsification and pancreatic lipase for hydrolysis. Then, inside intestinal epithelium, these components are reassembled into triglycerides and packaged with cholesterol and apolipoproteins into large lipoprotein particles called chylomicrons. These chylomicrons then enter the lymphatic system and ultimately the bloodstream for tissue delivery. In the capillaries of adipose and muscle tissues, an enzyme called lipoprotein lipase or LPL hydrolyzes the triglycerides in chylomicrons into free fatty acids and glycerol, which are absorbed by nearby cells for energy or storage. The remaining chylomicron remnants, now cholesterol-rich after losing triglycerides, would be carried to the liver by blood, where they are taken up and thus cleared from circulation. The other is the endogenous or hepatic pathway for synthesized lipoproteins, which comprises of 3 steps including 1. Formation of VLDL and LDL, 2. Delivery of triglycerides to tissues, and 3. Reverse cholesterol transport by HDL. The liver synthesizes lipids from excess carbohydrates and stores them as triglycerides. These are packaged into very low-density lipoproteins or VLDL, which are released into the bloodstream. Similar to chylomicrons, VLDL triglycerides are also broken down by lipoprotein lipase in peripheral tissues, forming intermediate-density lipoproteins and eventually low-density lipoproteins or LDL to transport cholesterol to tissues that need it for functions like cell membrane formation, hormone synthesis, and bile acid production. High levels of LDL are associated with atherosclerosis. To remove excess cholesterol, another lipoprotein called high-density lipoproteins or HDL, also synthesized in the liver and intestine, would carry out the reverse transport of cholesterol from peripheral tissues and transport it back to the liver for disposal or reuse. This diagram beautifully summarizes how cholesterol and lipids are transported in the body and where major anti-hyperlipidemic drugs act to modify these pathways. It integrates both the endogenous, hepatic, and exogenous, dietary, routes of lipid metabolism. Let's begin with the liver, the central hub of cholesterol regulation. Inside the hepatocyte, acetyl-CoA, ACoA, is converted into mevalonate, MVA, by the enzyme HMG-CoA reductase, the key rate-limiting step in cholesterol biosynthesis. Here, statins exert their major effect. They inhibit HMG-CoA reductase, thereby reducing cholesterol synthesis within the liver. As a compensatory response, the hepatocyte upregulates LDL receptors, increasing the uptake of circulating LDL cholesterol from the blood, which effectively lowers plasma cholesterol levels. Meanwhile, some of the synthesized cholesterol is converted to bile acids, which are secreted into the bile duct and delivered to the intestine to aid fat digestion. In the intestinal lumen, bile acids can either be reabsorbed into the enterohepatic circulation or bound by bile acid sequestrants, also known as resins, e.g., cholestyramine. When resins bind bile acids, they prevent their reabsorption, forcing the liver to use more cholesterol to synthesize new bile acids, again lowering hepatic and plasma cholesterol levels. Thus, Resins enhance cholesterol excretion in the feces. Now, look at the exogenous pathway, the handling of dietary fats. Dietary cholesterol and triglycerides combine in the intestine to form chylomicrons, which transport triglycerides, Tg, and cholesterol esters, Ce, through the portal vein to the liver. Within the circulation, lipoprotein lipase acts on these chylomicrons, releasing free fatty acids for use by muscle and adipose tissue. The remnants of chylomicrons, now rich in cholesterol, return to the liver for recycling. In the endogenous pathway, the liver packages triglycerides and cholesterol esters into VLDL, very low-density lipoproteins. As VLDL circulates, lipoprotein lipase again removes triglycerides, converting VLDL first to IDL and eventually to LDL. Low-density lipoprotein, LDL, delivers cholesterol to peripheral tissues but also contributes to atherosclerotic plaque formation when present in excess. At this point, fibrates act. They enhance the activity of lipoprotein lipase, accelerating triglyceride breakdown and reducing VLDL levels. They also decrease hepatic secretion of VLDL and increase HDL levels, promoting reverse cholesterol transport. HDL, high-density lipoprotein, often called the good cholesterol, collects excess cholesterol from peripheral tissues and returns it to the liver for disposal or reuse, a process enhanced by fibrates and other lipid-lowering agents. Cholesterol is synthesized endogenously from acetyl-CoA via the mevalonate pathway. The key rate-limiting enzyme is HMG-CoA reductase, which converts HMG-CoA into mevalonate. This process is tightly regulated because cholesterol is essential for cell membranes, steroid hormones, and bile acid synthesis. Most lipid-lowering therapies act by interrupting or modulating this pathway to reduce plasma cholesterol levels. The main pharmacological groups include statins, which work by inhibiting cholesterol biosynthesis at the reaction catalyzed by HMG-CoA reductase. Fibrates, which stimulate PPAR-alpha receptors. Niacin, or vitamin B3 in high doses. Bile acid-binding resins, such as cholestyramine and cholestyramine, and ezetimibe, which blocks intestinal cholesterol absorption. Some newly introduced unique drugs like PCSK9 inhibitors, ACL inhibitors, MTP inhibitors will examine each group's mechanism and clinical use in detail. Statins competitively inhibit HMG-CoA reductase, the enzyme converting HMG-CoA to mevalonate, the precursor of cholesterol. This inhibition lowers hepatic cholesterol synthesis, which triggers the SREBP pathway, upregulating LDL receptors on hepatocytes. As more LDL is cleared from plasma to meet the liver's cholesterol demand, serum cholesterol levels fall markedly. Hence, statins are the cornerstone of lipid-lowering therapy. Beyond lipid reduction, statins have pleiotropic effects. They reduce vascular inflammation and stabilize atherosclerotic plaques, making them less likely to rupture and cause thrombosis. Examples include simvastatin, as well as the long-acting atorvastatin and rosuvastatin as high-efficacy drugs, while lovastatin, pravastatin, and fluvastatin have moderate efficacy. These differences influence drug selection in clinical practice. Statins are generally well tolerated. The main concern is myopathy, so serum CK should be monitored, especially when high doses of simvastatin, greater than 80 mg per day, are used. Rare adverse effects include hepatotoxicity or lupus-like reactions. They slightly reduce coenzyme Q levels by blocking ubiquinone synthesis. Statins are contraindicated in pregnancy and lactation, and should be temporarily withheld during major surgery or severe illness. Thanks for watching. Don't forget to like, subscribe, and share. Happy learning!